the sinus embedded within the skull bone. It is only have a facial bone, have a sinus. You have other three sinuses, the frontal air sinuses, middle air sinuses, and the sphenoidal air sinuses. The maxillary sinus are air-containing space that occupy the maxillary bone bilaterally. The larger of paranasal sinuses, the maxillary sinus is called Infra, or call it maxillary sinus, or call it maxillary Infra. Short note about the embryology of the sinuses. The initial maxillary sinus development, also termed primary immunization. The first of paranasal sinus develop embryonically and begin in the third month of fetal development as mucosal invagination or pouching of the ethmoidal pedipalpa. Secondary immunization begins in the fifth of the fetal development as the initial invaginations expand into the maxillary bone. After birth, the maxillary sinus expands by immunization into developing alveolar process and extend anteriorly and inferiorly from the base of the skull, closely matching the growth rate of maxilla and development of the dentitions. By the time a child reaches age 12 to 13 years, the sinus will have expanded to a point at which the floor will be on the horizontal level as the floor of the nasal cavity. So, the floor of maxillary sinus within the level of the floor of the nasal cavity. Expansion of sinus normally occurs after eruption of permanent teeth, but on occasion the sinus will pneumatize further after removal of one or more posterior maxillary teeth to occupy the residual alveolar process. The maxillary sinus is significantly larger in adult patients who are edentulous in the posterior maxilla compared with the patient with complete dentition in posterior region. This figure shows how the development of maxillary sinus and in relation to the nose and to the orbit. So, the left maxillary sinus within the maxillary bone that have any first newborn maxillary sinus and expanded first year, fourth year, 7th year, and the 12th year, and in early adult and adolescent after extraction of the upper molar teeth. We can compare with the orbit that have in 1 year, 2 year, 4 year, 7 year, and in the 12 year and adult within the frontal sinuses. Now, the anatomy of maxillary sinus. The maxillary is four-sided pyramid in shape, with the base lying vertically on the middle surface forming the lateral nasal wall. The apex of the maxillary sinus extends laterally into the zygomatic process of maxilla, so the upper wall is formed. The roof is also floor of the orbit. The anterior wall related to the soft tissue of the cheek. The posterior wall extends into length of maxilla and deep into the maxillary region of first premolar or canine and related to pterygopalatine and infratemporal fossa. The floor of the sinus forms the base of alveolar process. It is above the apices of the premolar and molar teeth of upper region. The adult maxillary sinus averages 34 mm in anterior-posterior direction and 33 mm in height and 23 mm in width. The volume is approximately 15 to 29 milliliter. This is the dimension of the maxillary sinus. The sinuses are primarily lined by respiratory epithelium. The mucosa secreting pseudo fascillated columnar epithelium. So its epithelium, it is like the nasal cavity is pseudo cystified columnar epithelium. The sinus opening, or call it ostium, lie 2/3 the distance of the medial wall base of the sinus and drain into the nasal cavity into posterior or inferior end of the semilunar hiatus, which lie in the middle meatus. So it is the last sinuses that open with the semilunar hiatus within the small pedipedalum and middle meatus, and it is higher than the floor of the sinus. The infra-orbital nerve lie within the groove which bulge down into the roof of the sinus. This infra-orbital nerve that emerge through the infra-orbital foramen that have the end branch of maxillary nerve that enter through the infra-orbital groove, a fissure to the infra-orbital canal to infra-orbital groove to the infra-orbital foramen that have the floor of the orbit and at the same time the roof of maxillary sinus. This figure shows the supply of the arterial blood supply of maxillary sinus by the maxillary artery that have branch through the infra-orbital artery and through the superior labial artery that supply the maxillary sinus. How we can do clinical examination of maxillary sinus? We see in this figure the sinuses within the head. The first one, F, frontal sinus, and the ethmoidal sinuses within the maxillary sinuses at the side of the nasal cavity and open within the nasal cavity through the opening. The opening of maxillary sinus is called ostium that have within the above the floor of maxillary sinus into the nasal cavity. Clinical examination of patient with suspected maxillary sinusitis should begin with a careful examination of patient face and intraoral vestibule for swelling or redness. Nasal discharge may be evident during the initial evaluation. The examination should also include tapping of lateral wall of the sinus externally over the prominence of the cheek bones and palpitation intraorally on the lateral surface of maxilla between the canine fossa and the zygomatic petrous. The affected sinuses may be very tender to gentle tapping or palpitation or erosion of the lateral wall of the sinus of maxilla with palpable defects. حقيقة, when there are infections, there need to erosion of bone and the thinner part of this bone were adjacent to the cheek. So there are no any bony septa, and there are tender when percut in the cheek area in middle region, or when palpated in the vocal vestibule that have lead to a palpable and fluctuant sinus. Other examination, transamination of maxillary sinus by placing a bright fiber optic light against the mucosa on the parietal or facial surface of the sinus and observing the transmission of light through the sinus in a darkened room. The involved sinus show decreased transmission of light because of the accumulation of fluid, debris or pus, and the thickening of sinus mucosa. This simple test may help to distinguish sinus disease, which may cause pain in the upper teeth from abscess or other pain of dental region associated with posterior teeth. If misdiagnosed, we do this transamination for sinus to differentiate between the maxillary sinusitis or periapical lesions. Other investigation is radiographic examination. We take the most perfect examination for maxillary sinus and other sinuses is occipitomental view, or call it water view. This can see the bilateral maxillary sinus and the frontal sinus and compare it with the orbit to see if there are reduced sinus radio lucency, and go to radio opacity if there are present fluid or spas or other thickening of mucosa. The standard dental radiography may be useful in evaluating the maxillary sinus. Include periapical radiography. Is limited to only a small portion of inferior aspect of the sinus can be visualized. In some cases, the apex of root of the posterior maxillary teeth may be seen to project into sinus floor. Second, panoramic radiography may be provide a screening view of maxillary sinus to provide a view of both maxillary sinus for comparison. And the last one, occlusal radiography for upper jaw. These radiographs are of value in locating retrieving foreign bodies within the sinus as teeth, root tips, osseous filaments that have been displaced by trauma or during tooth removal, mean tooth extraction. Other extra-oral view technique is occipitamental view, or call it Waters view, is taken for paranasal sinuses, for the frontal sinus, maxillary sinus, and for ethmoidal sinuses. The lateral view can be obtained in standard cephalometric machine. Cephalometric view to see the unilateral sinus and diagnose it and compare it with the frontal sinus and orbital cavity. The computerized tomography is a useful technique for imaging of maxillary sinus if there are any things that lead to have a malignant disease. The finding in normal antrum a large air-filled cavity surrounded by bone and dental structure. The body of sinus should appear radiolucent and outline well-demarcated layer of cortical bone. Comparison on side with other is helpful. This periapical view shows the floor of maxillary sinus extended in the alveolar process between the second molar and the second premolar after long period of extraction of first molar. This orthopathologram view shows to compare the right and left side of within the maxillary sinus and the nasal cavity and its relation to upper dentition. This occipitamental view is to see compare the two maxillary sinus right and left side within the orbital cavity and the frontal sinus. This view shows the computerized tomography to see the section, the coronal section, to see the maxillary sinus, the ethmoidal sinus, and the nasal cavity if there are any abnormality within this technique. The radiographic investigation that include the thickened mucosa and the bony wall, air fluid level, mucus pus or blood or foreign bodies. Partial or complete ossification of maxillary sinus may be caused by the mucosal hypertrophy and fluid accumulation of sinusitis by filling with the blood following trauma or neoplasia. Mucosal thickening caused by infections may obstruct the ostium of the sinus and allow accumulation of mucus, which will become infected and produce pus. The characteristic radiographic change may include an air fluid level in the sinus, thickened mucosa on any or all sinus cavity. The radiographic changes indicative of chronic maxillary sinusitis, including thickening, sinus obstruction, and nasal or antral polyps. Air fluid level are more characteristic of acute sinusitis, sinus disease, but may be seen in chronic sinusitis in acute exacerbation when changed from chronic to acute state. Disruption of cortical outline may be a result of trauma, tumor information, and an infectious process will abscess and fistula formation, or surgical procedure that violate the sinus wall. Expansion of bony wall may also be apparent. Dental pathology conditions such as cyst or granuloma may produce radiolucent lesions that extend into sinus cavity. These conditions may be distinguished from normal sinus anatomy by their association with the tooth apex. This figure CT as a coronal section that you can see that have complete ossified right maxillary sinus in compared with the left side. The diseases that affect maxillary sinus is maxillary sinusitis. We have two categories to have maxillary sinusitis. First, non-odontogenic infection and other odontogenic infection. The non-odontogenic infection, the mucosa of sinus is susceptible to infection, allergy, and neoplastic disease. Inflammatory disease of sinus such as infection or allergic reaction cause hyperplasia and hypertrophy of mucosa and may cause obstruction of the ostium. The mucus produced by the secretory cells into lining the sinus are collected over long periods. Bacterial overgrowth may begin produce an infection resulting in the signs and symptoms of sinusitis as well as radiographic changes. When inflammations develop in any of paranasal sinuses were caused by infection or allergy, the condition is described as sinusitis. Inflammation of most or all of paranasal sinus is known as sinusitis and is usually caused by infection. Similar condition of divided individual sinus as maxillary sinusitis. حقيقة إذا شملت الماكسيلاري sinus والfrontal sinus and middle sinus هذه three sinuses call it sinusitis. Acute maxillary sinusitis may occur at any age. The onset is usually rapidly developing sense of pressure, pain, and/or fullness in the vicinity of the affected sinus. The discomfort rapidly increases in intensity and may be accompanied by facial swelling and earthing, malaise, fever, and range of foul-smelling mucopurulent material to nasal cavity and nasopharynx. Chronic maxillary sinusitis is usually a result of bacterial or fungal infection that allow great and recurrent obstructive nasal discharge or allergy. It is that either bacterial infection or fungal infection or result allergy. It is characterized by episodes of sinus disease that respond initially to treatment, only return or that remain symptomatic in spite of treatment. We have two types of bacteria, the aerobic and anaerobic or mixed bacteria may cause infection of maxillary sinuses. Mucostasis that occur when the sinus allow colonization of this organism. The important aerobic bacteria are Streptococcus pneumoniae and Haemophilus influenzae. The anaerobic bacteria include Streptococcus viridans, Staphylococcus aureus, Enterobacteria, Bacteriaceae, and Eubacterium and Fusobacterium. Another type of infection is odontogenic infection. The maxillary sinusitis is occasionally a result of odontogenic source because of the anatomic juxtaposition of teeth and the maxillary sinus. Odontogenic source account for approximately 10 to 12% of all maxillary sinusitis. This condition may rapidly spread to involve the other paranasal sinus if left untreated or inadequate treatment. In rare cases, this infection becomes life-threatening and can include cellulitis, cavernous sinus thrombosis, meningitis, osteomyelitis, intracranial abscess, and death. حقيقة علاقة الساينسز within intracranial by the vein drainage of the maxillary that have drained to the ophthalmic vein that go to the cavernous sinuses and have any infection travel to the sinus, lead cavernous sinus thrombosis, and lead meningitis, and then intracranial abscess, and after finishing the death of patient. The relation of sinusitis with the bone that have lead to osteomyelitis, and that is relation with the soft tissue of the cheek and the pharynx lead to cellulitis. Sources of allergic infection include acute or chronic periapical disease and periodontal disease, lead from trauma to the dentition or from surgery and posterior maxilla, including removal of teeth, alveolectomy, tuberosity reduction, sinus lift grafting, and implant placement, or other procedures that create an area of communication between the oral cavity and maxillary sinus. Maxillary sinus infections of allergenic origin are more likely to be caused by anaerobic bacteria. The predominant organisms are aerobic and anaerobic streptococci, and anaerobic bacteroid, enterobacteriaceae, and Eubacterium that lead to allergenic infection of sinusitis. Treatment of maxillary sinusitis. First, humidification of inspired air to loosen and aid in removal of dried secretions from nasal passage and the sinus ostium. Systemically administration decongestants such as pseudoephedrine, nasal spray containing vasoconstrictors such as 2% cefadrine or 0.25% phenylephrine. Non-steroidal or narcotic analgesic may be appropriate. Antibiotic is indicated. If there are non-allergenic sinusitis, antibiotic choice treatment include amoxicillin, trimethoprim, sulfametazole, amoxicillin, clavulanate, as augmentin, and azithromycin and cefuroxime. In allergenic infections such as penicillin, clindamycin, and metronidazole are effective for treatment of sinusitis. Culture and sensitivity tests. Whenever possible, sensitivity testing may suggest a change to another antibiotic if resistant organism, if the infection is failed to respond to appropriate treatment within 72 hours. خلال 3 أيام إذا ما تعالج من خلال هالordinary antibiotic, you must do culture and sensitivity test. 25% of organisms cultured from acute sinus infection are beta-lactamase producer, and many be anaerobic, especially if the infection is allergenic, so use another antibiotic such as combination agent. We use combination antibiotic like trimethoprim and sulfametazole, combination of amoxicillin and carbonate potassium as augmentin. The cycle of the sinusitis that have first, blockage or swelling of the sinus opening lead to osseous blockage, increase in and abnormal mucus secretion. This leads to mucosal stuck and won't drain. This leads to sinus infection, and this sinus infection continues the cycle of the sinusitis. How diagnosis of the sinusitis is the treatment of chronic maxillary sinusitis is difficult and may include allergic test, nasal or septal surgery, surgical debridement of the sinus. We do if the allergic sinusitis lead to chronic maxillary sinusitis that do allergic test, and there are surgery for if there are any problem within nasal cavity or deviation or polyp within the nasal cavity, and septal of the nasal cavity do lead to have any surgery, and debridement and curate of the sinus in surgical operation. The goal of sinus surgery is to move abnormal tissue from within sinus cavity and restore normal drainage through ostium. The approach to sinus known as called Bullock procedure. The anterior wall of the sinus is accessed in the area of canine fossa through vestibular approach. The sinus is opened and abnormal tissue or foreign body can be removed. Second type, antrostomy, is opening for more drain into nose can be created near the floor of the sinus. Other newer technique allow exploration and surgical treatment of sinus with less invasive endoscopic approach. We use endoscopy that create the sinus. This figure shows how the cold lock procedure do an incision from the canine to premolar and expose the buccal side of the sinus, and after that we do drilling on the wall of one wall and then open to see the maxillary sinus wall to do any create that have curate and remove any foreign tissue or any mucus thickening of polyp within the maxillary sinus cavity. Other thing within the maxillary sinus is sinus lift procedure. This procedure leads to complications become more frequent in at least two instances: when the sinus membrane is severely lacerated or avulsed, when the sinus is overfilled. The treatment consists of infection control, surgical removal of contaminated or deviated graft material. These are usually accomplished through cut or lock surgery, lateral sinus or surgical approach, earlier with nasal access, endoscopic sinus surgery. Other diseases that affect the sinus: antral cysts, beginning accumulation of fluid underneath or surrounded by sinus epithelium. These have three types of cysts in the maxillary sinus. First one, pseudo cysts, and mucocele and irritation cysts. This may appear a faint radiopacity within the sinuses. There are septa that separate the cysts from the sinuses. The first type is antral pseudocyst. It's seen in 2 to 10 of panoramic radiography. This pseudocyst is a result of accumulation of serum under the sinus mucosa. The cause of this accumulation is not clear but may be related to inflammation of the sinus lining. These lesions are of no clinical consequence, require no treatment, and often disappear by time. The second type, sinus mucoses, are actually cystic lesions so that they are lined by epithelium. The most common cause is surgery on the sinus that results in separation of portion of sinus lining from the main portion of the sinus. This area can fill with mucus and walled off, forming a separated cystic lesion, so called surgical ciliated cyst or post-operative maxillary cyst. This lesion can become expansional and may expand or erode the wall of the sinus, and most differentiated through removal and biopsy from more aggressive and even malignant lesion of the sinus. The third type, retention cyst, results from blockage of duct within the mucus-secreting gland within the sinus. The accumulated mucus mucin become surrounded by epithelium, forming a true cystic lesion. These lesions are usually so small as not to be seen on radiographic image. Other categories is the complication of oral surgery involving maxillary sinus. This complication due to displacement of teeth, root, or instrument fragment into the sinus, or creation of a communication between oral cavity and the sinus as oral nasal, oral antral communication, or oral antral fistula. A sinus perforation result from a tooth extraction most commonly occur when the maxillary molar with a widely divergent root that is adjacent to the edentulous space requires extractions, which become pneumatized into the edentulous alveolar process surrounding the tooth, which working the entire alveolar and bring the tooth abscess into closer relationship within sinus cavity. Second, abnormal long root. Third, dissection of a portion of lower and sinus by apical lesions. Fourth, perforation of floor and the sinus membrane with the injudicious use of instrument forcing a root or tooth into the sinus during attempt removal. Fifth, removal of large cyst lesions that encroach on the sinus cavity. This figure shows the isolation of the upper dentition, the maxillary teeth within the floor of maxillary sinus. This figure shows that have the upper first molar, the palatal root and the mesobuccal root that have within the cavities of the sinuses that have a cyst that lead to a thin bony septum between the cyst within the sinus. This figure shows the oropantral fistula between the oral cavity and the maxillary sinus. In many cases, the opening is small and primary closure can be easily accomplished with adequate healing, but in larger perforation or a communication is apparent and routine closure is not possible or not adequate to cover the opening. The treatment of oral enteral communication is accomplished immediately when the opening is created or later, as in the instance of long-standing fistula or failure of an attempt primary closure. Oral enteral communication, or call it immediate communication that have done immediate treatment. If the opening of the sinus is small and the sinus is disease-free, sutures are replaced to reposition the soft tissue and goes back to the place of the surgical site for 1 to 2 hours. The patient is instructed to use nasal precautions for 10 to 14 days, which include opening the mouth while sneezing, not sucking on acetone or cigarettes, avoiding nose blowing, and any other situation that may produce pressure change between the nasal passage and the oral cavity, and give him antibiotic, usually penicillin and antihistamine and systemic decongestant for 7 to 10 days to prevent infection, to shrink mucous membrane, and to lessen nasal and enteral secretion. The patient is seen post-operatively at 48 to 78 2 hours between 2 to 3 days interval and instructed to return if an oral enteral communication becomes evident by leakage of air into the mouth or fluid into the nose, or if symptom of maxillary sinusitis is repeated. If large perforation occurs, it may be necessary to cover the extraction site with some type of flap advancement to provide primary closure in an attempt to cover the sinus opening. The most commonly used flap involve elevating vocal flap, releasing the periosteum and advancing the flap to cover the extraction site. This figure shows diagram that have closure of oral enteral communication by autogenous graft, allogenous graft, xenograft, and symmetry, synthetic material, or other technique. This overview of the treatment modality of oral enteral communications. The delayed treatment is called oral enteral fistula. The method for closing oral enteral fistula are advancement buccal flap, rotation palatal flap, advancement of palatal and facial flap over the membrane. In large defect, use pedicular flap from the tongue or temporal muscle or fascia, temporal fascia. This figure shows a technique that have a buccal advancement flap by releasing from the buccal side and excise the round margin of the orifice of fistula, and then suture within the palatal side and close it. This figure shows the palatal rotation flap by size the flap around the greater palatine artery and rotate it and suture with the buccal mucosa. Thank you for your listening this lecture.